managing the high intensity needs funding process in your homes, and hopefully you have some really good tips on us or for us. So that's Susan, and you'll have to forgive me if I mispronounce your last name. Give it a try. Cymbaluk.
That's right.
Excellent, excellent. So Susan Cymbaluk is the Operations Manager of Clinical Services at OMNI Healthcare.
Good morning, everyone. Can you hear me? I tend to talk a little bit fairly quiet. So this morning, as they've talked about, my slides and my presentation is really about things that OMNI Healthcare is doing in order to meet the needs of the HINF funding model. Certainly, some of them may seem to be prohibitive in time and energy for each nursing department to do, but certainly it has made a huge difference for us to manage the costs and make sure that we get as much of that 95 and 5% split back to the homes. So certainly the 4 categories, we put in best practices for supplemental staffing, preferred accommodation, dialysis transportation, and exceptional wounds. So certainly I'll start with supplemental staffing. So generally speaking, anytime you put a new form into place or a new initiative, a new best practice, of course it follows up. You have to have a policy, and all these new fundings, everything has a new policy. So we do have some excellent policy writers within the company, so they were able to make a user-friendly policy that covers everything in regards to one-to-one staffing. It allows the home to track and get approval through a requisition form, and it goes through the first 72 hours, the next 72 hours, and then continues on for as long as one-to-one or supplemental staffing is required. Now, certainly, we have had very good benefits for that we can make sure we have the hours right down to a science every week, every day, every shift, so nothing gets missed, and we're able to do those submissions really quite accurately. We also have very specific communication between each home, and we have 18 homes, so certainly between each home, their regional director and our financial department, and we have monthly reminders to make sure that those staffing hours are calculated, and we do monthly calculation checks with the homes as well to make sure that they are right on top of those submissions. And we have been successful in having every one-on-one approved at the 95 and 5% split, so the homes are not having to eat the cost of that one-to-one staffing. So preferred accommodation, generally, historically, it has been fairly difficult to make sure that we are able to get the funding back for preferred accommodation. So we did put new best practices in place for communication with finance and communication with the administrator and directors of care. And by having those weekly calls, monthly calls, and it is also part of our communities of practice discussions with admins, we are able to track those costs and get reimbursement. Certainly, sometimes it does take a few letters, a little bit more communication, a few more submissions that maybe we had before, but certainly we're quite committed to do that. Dialysis transportation, this is one area where we haven't had a lot of changes for our homes. Certainly we do have, pockets of dialysis patients, depending on where we are in the province, but we've actually only had one particular claim not accepted based on the exorbitant costs for that transportation, and certainly one of the things I've kind of pushed is we're really not taking no for an answer, and we do go, and I'm very strong in that belief that we do go back to the ministry, we do resubmissions, and we do prove our case that we really have the best transportation, we have the best cost for that particular person, and certainly a lot of our homes are rural in the sense that, it's a half an hour, 45 minutes, even an hour to their dialysis transportation, and there's only certain vehicles our residents fit in. So we do make a very good case, and we do get our submissions accepted. So I think this is the biggest one that we have done the changes for in all our homes in our nursing departments. And it took a good 6 months, I guess, to develop care plans and treatment plans that allowed all the homes to do their own assessments. They stage the wounds, and they make sure that they have the best practice treatment plans for every wound that they could possibly have, whether it's a pressure ulcer, venous stasis, arterial, whatever it may be. We have treatment plans that streamline the entire process from start to finish, and for the most part, we are getting our reimbursements back. We also grow our own talent within OMNI. We educate our staff to make sure that we have wound care consultants in all our homes, or one per 2 or 3 homes, so that also reduces the cost for ET referrals. So that helps, there's a little cost saving for that as well. We also do weekly audits, monthly audits, going through expenses. And, we've done something, it seems a little bit silly, but we actually have like a particular stamp. And every invoice that is for exceptional wounds, we batch it in a certain way so we can streamline and know exactly what everything costs. And it allows us to know right to the last penny what our costs will be, and it helps to ensure that we are able to get our 95% back. Also, as part of my role within the company, it's consulting with the homes and making sure the homes in their exceptional wounds, that they have what they need, that they have the treatment plans, they understand, they're using them, and they're using the audit process just to keep track of time study, how much does it take to do that particular wound, and can we manage it, and certainly when we have those packages from CCAC and it indicates that, a resident has a stage 4, it is deemed chronic. We will do visits to wherever that potential resident may be, and make sure that we can manage it. Cost is not necessarily the end factor if we were not to take that particular resident, but it's certainly managing them within our current resident caseload and that sort of thing. And I must say we have had lower statistics, lower prevalence in our wound care, and we are able to manage those exceptionally well. These are just a couple of other things that we do in order to make this funding model work. I talked about the particular stamp. It was a $25 cheap cost item, a little webinar to teach people how to use it, and it works. So, you're not losing invoices, you're not, backtracking and trying to figure out, is that really an HIN or is it not? And certainly over in the last year, we do a hand-by-hand check of every invoice that's batched, and we do make sure that it is going to the correct place and under the correct resident and the correct nursing department. We also have gone so far as to change our budget logs. Every budget log has the HIN. We have high-intensity needs 100%, and we track those items I guess the 10 items that we did not, or they're not covered anymore. We've continued to track what those costs would be over the last year, just to see where we sit with utilization and are we able to manage those. We also have budget lines for the 95% and the 5%. Now, I'm certainly not a financial person by any means, or an Excel spreadsheet kind of person, but it does work. It does all calculations, and it really gives the home a good idea of what they're spending. And one of the final things that we did to try and make sure that our G2 feeds, and we do have those one-off kind of formulas that are super expensive and take up the entire budget. We have gone so far as to actually change our supplement program within all our homes. Pardon me, it's a nursing pass supplement. It is ordered by the dietitian. It's based on weight and requirement needs for the resident, and it does reduce time, it does reduce waste, because a lot of times residents will still lose weight on supplements, and we have actually, since we've put this into place, in just a short 3-month time frame, we have 90% compliance with taking their supplements. They're eating their meals and they're gaining weight. So then, of course, the supplement's discontinued. So that's one of the huge successes, really, for us. The nurses, initially, there's a little bit of pushback. Oh, it's one more task doing my med pass. But we were able to discuss and look at those options, and they're accepting it pretty well, actually. And really the final thing that we do as a best practice is anytime something comes back as a no, we're not accepting this, we always research, redo it, and resubmit. Unfortunately, sometimes it's 20 times we resubmit, but we do resubmit. We are, yes, we do persevere and make sure that our program is the best it can be. We ensure quality for the residents, as well as being fiscally responsible. So that's it for me.